In the world of public health, data sharing is crucial for informed decision-making. State and local health departments are pivotal players in this effort. Smaller rural counties specifically face data access challenges due to limited IT systems and informatics workforce capacity. Data disaggregation and governance standards also impact rural regions due to smaller sample sizes. Organizational policies like data sharing agreements and departmental protocols can improve data exchange locally while improving data exchange at state and federal levels. Success depends on understanding challenges, assessing policy tools, ensuring readiness for change, and working across state and local levels of government to improve the availability of timely public health data. Minnesota provides an example of how a state public health department is supporting a larger county health department, which in turn is supporting a smaller regional counties to share and access important data to help with reporting and to develop data-informed community programs. I'm Rima Mistry, Director on ASTO's Public Health Data Modernization and Informatics team, and today we are joined by Susan Brace Atkins, Systems Change Consultant, Minnesota Department of Health, Tina Jordahl, Program Manager, Olmsted County Public Health Services, and Tammy Fiedler, Public Health Director, Wabasha County Public Health Department. Susan, can you tell us a little bit about your role with Minnesota Department of Health and how you support the local health departments in Minnesota?
Of course. I'm one of the consultants, planners that works in the public health practice section of MDH. And my role is really about building capacity and improving the performance of the system, which includes in Minnesota both the state health department, local public health departments, and tribal health departments. And usually our support is sort of customized training, technical assistance, consulting, coaching, kind of serving as a liaison between our local, tribal, and state health departments.
Wonderful. Thank you. Tina, can you tell us about Olmsted County and the relationship with smaller counties?
Yeah, I'll start by talking a little bit about Olmsted County itself. So we are the 7th largest county out of 87 in Minnesota. We have a total population of 164,000 residents. So our partnership with our regional counties, there are 11 counties in Southeast Minnesota that really band together and partner on initiatives. And they make up the Southeast Regional Local Public Health Association. And they range in population from 18,000 residents to 55,000 residents. So very rural counties, but important in their community. So describing the relationship that we have with our counties, we partner on a lot of initiatives in the Southeast region because we are outside the metro. We do experience different public health dynamics than what might be experienced in the metro, the St. Paul, Minneapolis area, as well as Northwest and Northeast Minnesota, which also face different public health challenges. We face our frontline staff partner on initiatives around everything from drinking water to emergency preparedness. And then this project where we're collaboratively looking at data together as a region, because our region, again, faces different trends than the metro does. And so it's been really powerful bringing this group together and looking at data in that way and just building off those existing relationships we have.
Tammy, how did the challenges differ in smaller counties such as Wabasha?
Sure. As Tina mentioned previously, we're one of the smaller rural counties. And so having the IT workforce and infrastructure behind that to do our own data gathering and sharing is a challenge for us. My health department only has 18 staff. And so this regional partnership with Olmsted County and the others has really helped us go through the smaller sample sizes, but also then to compare our local data with regional and state data. Data suppression in a small county is important so that we're not identifying anybody. And we're using this specifically with our opioid settlement work currently. So it's important to keep people private as much as possible, but also share the challenges that we're seeing with the opioid epidemic in our area.
Tina, how did the data sharing partnership with Minnesota Department of Health evolve?
So we started this pilot and we wrote in for the infrastructure grant And we wanted to develop data sharing partnerships and agreements with not only the Minnesota Department of Health, but also with our regional counties and our partner counties that allowed us to access their line list data for them. So with the Minnesota Department of Health, we initially formed the agreements with our regional partners. And so we learned a lot in contracting and accessing data at a local level. And that's how we journeyed down this road. Other divisions of the Minnesota Department of Health, it was easier to work with. They didn't have as many data restrictions. And so we were able to partner with those epidemiologists using our data sharing agreements with counties like Tammy had mentioned with Wabasha to actually request and securely store that line list data on our servers and then do data summaries and provide authenticated two-factor protected access so that even smaller counties could access that data that couldn't be published on the website, which is primarily how the wonderful EPIs at the Minnesota Department of Health share data.
Susan, is there anything you can add about the data sharing relationship between Minnesota Department of Health and Olmsted County?
The whole story about this really was Tina asked for it, and we got all the people in the room that, from vital records, from health statistics, legal staff, leadership, and we asked, they asked, Olmsted said, why can't we have this data? And it was kind of amazing because our legal staff said, you can. We just need an agreement. And so I think it's just a really good story about how oftentimes in terms of data, we don't even think about kinds of data that we have in a statewide level. It started with an ask.
Oh, wonderful. Tina, legal and regulatory issues are often perceived as barriers to data sharing. What kinds of data sharing agreements have you implemented, and what was that process like?
I mean, I have to give credit to Susan in her role at MDH, and that role is crucial in helping us because, again, we had not done this before. And so just figuring out what do we need and what does MDH need and expect from us to have in our local data sharing agreements. We outlined how we would ask for the data, how we would securely store the data, how we would share the data. We only are allowed to share aggregate data. Other counties, for example, if Tammy would like her line list data, she can get it. She just has to request it herself. We're not allowed to share that with Wabasha County. And so outlining those different agreements of here's what we intend to do with the data, making sure we're abiding and protecting protected health information is crucial and important. And a lot of counties, especially rural counties, were reaching a little bit of a stalemate in that their data just wasn't available on public-facing dashboards because they didn't have enough data in categories to meet data suppression guidance. But it doesn't make that data any less important. And so we also included in our practices, we outlined and contacted every data source epidemiologist or owner at MDH and asked them, what is your data suppression guidance? And we put together an internal document where we can refer to that. And so instead of developing a standard data suppression guidance, we've taken the approach that we do it by data source and do it with what the data owner is comfortable with.
I just want to add to that because our role at MDH and our work, we are trying to do better, right, in terms of sharing data with our local and tribal health partners. And I think Tina's story is illustrative of what the process looks like right now at MDH, right? There's different owners. The owners of data are throughout the whole department. And so we are a work in progress, right?
Wonderful. Thank you for adding that. Tina, I have another question for you. What kinds of workforce strategies have you pursued to support smaller counties?
Yeah, so we replicated our model, which really focuses on population health data, not infectious disease data. Currently in the Minnesota Department of Health, there are what are called field epidemiologists. And so our Region 7 has a field epidemiologist, But that individual and that appy really focuses just on infectious disease. And so we noticed in talking with our partners, and especially as Tammy had mentioned with the opioid settlement, there was a lot of data needed outside of infectious disease. And with the new foundational public health responsibilities, and we are in a larger area for Minnesota, it can still be challenging to hire, but we did really want to find a good fit for those positions of epidemiologists, those that had data skills that were really focused on population health data outside of the infectious disease bucket, but that also were able to relate to the needs and facilitate conversations with our amazing local partners like Tammy and other smaller counties, and to be able to translate what their needs are into action. And so I guess with workforce strategies, that's how we went about it. Even in our county, it was not without its challenges. We had to open the position multiple times before we found the right fit. And so we ourselves experienced what that hiring challenge is like. And we also watched our partners and are walking the journey with them of a lot of them are trying to hire data people. And it's really challenging in rural areas to find folks that have those skills and that are in the area.
Thank you, Tina. I'm going to ask a follow-up just to add a little bit about how you leverage your informatics workforce to support the smaller counties and what kind of partnerships you have built so that they're able to support some of those population health activities for the other counties in addition to Olmsted County.
From an informatics and data perspective, we were requesting this data for Olmsted County anyway, and we were going to analyze it anyway for our county. And we thought it really is, the data are all structured the same based on the source. And we asked for it for our partner counties as well, because again, it's the same data, it's just switching the location code. And it's been fun to see it play out. And it's not, again, we needed funding from the state. It did require FTE, but we had the skills here and thought, this to us is also equity in ensuring that our regional rural partners have access to the same data that we do.
Wonderful. Thank you. Tammy, would you like to add anything to this?
Yeah, I would like to echo Tina's words and say to the group, Wabasha County wouldn't have been able to do anything like this without this partnership. We don't have the capacity to undertake something like this and build it from scratch, or the knowledge. And as she mentioned earlier, just the hiring process can take a long time, for one thing, to find the correct person. So to be able to partner when many of us work together and compare ourselves to other counties in the region and as a region as a whole to the state just made sense to me. And we are so thankful for, the state's part in this, but also for Olmsted County for representing our region and thinking outside the box and coming up with a solution like this that is good for everybody. So,
Tina, you mentioned a little bit about health equity. How do you incorporate health equity considerations in your work?
Absolutely. I mean, we take what most people I think would define as the traditional health equity approach, where when we get data, we do look at it by the different demographic categories, such as race, gender, sexual orientation, age. We also look at it in our rural counties. We also look at it by things like socioeconomic status. And so that's a big one. Something else that in talking with our regional partners, which I know we'll talk about later, things that are important, but communicating and just having conversations with our regional public health departments. We had a regional public health director who said, I would love fatality data based on birth location. And just thinking about, they have a large community that does mostly home births in their county. And for them, that's equity, to see what are the births occurring at home compared to those occurring in a facility. And it's again, applying that equity lens, but in a way that fits our rural counties and our rural area.
Tina, what kind of IT infrastructure or data governance solutions do you have in place to support your data dashboards?
Yeah, so we follow the Minnesota data governance as well as HIPAA when we are putting together dashboards and accessing data, requesting data, storing data, and then also releasing data. We are able to, with two-factor authentication, provide dashboards that do have sensitive data on them, but in a way that only those with the need to know can see. So for example, we recently in Minnesota, with the tremendous help of the Minnesota Department of Health, were able to gain access to syndromic surveillance. And that included North Dakota, Minnesota, and Wisconsin's data, which for a county like Wabasha and some of our other counties that are on the Wisconsin border, this was a huge step forward in giving them a little bit bigger picture of what's happening in our world.
Wonderful. Thank you. It does take a village to do this. Okay, so this is a general question, and I'll pose it to each one of you. Can you share some success stories? I'll start with you, Tina.
I think a success story, and this is for me personally, I have a passion in rural health and from a rural area myself. I grew up there. And so just being able to provide our public health directors, our frontline staff with the data to inform decisions to improve health for their populations has been a huge success. Signing agreements with MDH, developing relationships with epidemiologists within MDH, and walking this journey together with Susan and her team of, we don't know the answer, so we're going to keep pushing and we're going to keep asking. That's been a huge success. Just hiring people has been a huge success, and having 2 epidemiologists on board. And I'm going to do one more success. It's just these amazing relationships that we've also built with our public health directors and public health frontline staff. We're entering a point where they're asking questions, the tough questions about like, where do I find this data and help me use it? And that is just incredibly exciting for those of us that live in that big data world of, we love the data, and now like we're so excited to see that it's been implemented.
Wonderful. Tammy, what are some success stories that you could share?
So we're currently working on our opioid settlement planning and working to meet with municipalities, community stakeholders, as well as county stakeholders. And without this data to be able to share kind of the readily available trends that are in our area, it wouldn't be as meaningful, I don't think, to make the plan moving forward and how our county and its residents wish to pursue opioid settlement dollars and their use. For example, in our county, we've learned through the data that, we don't have as many fatalities as our bigger county partners, but we do have a real passion here for prevention and moving forward. And so focusing on that and seeing that from the trends is important in the planning process.
Wonderful. And Susan, what are some success stories that you can highlight?
Well, the first one I would say is really, we consider this Olmsted project kind of we were lucky enough that our Minnesota legislature gave us money, the Department of Health's annual funding for innovation. And this project really has been successful because of all the work that Tina and her staff and the regional directors and staff have done. And so we see it as kind of a model for the rest of our state. I know that Tina is getting calls from a number of other health departments across the state, and we're thrilled about that because it does show like this is another way to do this work, right? Because we're never going to have enough money for every county in Minnesota to have its own data analysts. I mean, they could give us tons of dough, and we would just never have that. So that's a real success that MDH sees, and it's really due to all of their work. The other success really is we started this agreement in getting this mortality and natality data in February of 23, and the actual agreement was signed officially, I think, early February of 24. So I see this as a really huge success for our agency, even though everyone said, yes, it can be done. As a state agency, there's a lot of hoops to go through, and we got this done, and it's going to be, again, a model for others. And in fact, we're putting this data sharing language into our master grant contract in 2025 because we've proven it can be done, right?
And one last question. Tina, what are your key recommendations for other jurisdictions working towards similar goals?
Yeah, I thought a lot about this question, and I think a couple of things would be to seek constant feedback and just be in communication and updating your public health directors and your state health department. It's okay to ask questions, be ready for barriers and detours, but don't get discouraged. And we just kept moving forward. And sometimes I know a project that we initially outlined was around mental health and mental health access. And unfortunately, we had to be honest with our partners that there is just a lack of data, county level data on this topic, and we will keep trying, but we had to say, we understand the importance and we just can't provide that for you. And so then moving on to the next project. I think the other thing that we're learning, and we have conversations with Susan about this too, is a one-size-fits-all model isn't necessarily going to work for everyone. So what we're doing in the Southeast region might not work in even the Northwest region of Minnesota. And yeah, just keep moving forward and celebrate the successes and learn from the hiccups and keep pushing forward.
Wonderful. Tammy, what are your key recommendations for other jurisdictions doing similar work?
I too think it really is dependent on the communication, and as Susan alluded to, patience. It doesn't happen overnight, and having good communication from the lead on the project is always helpful, so that you know what to expect, what the next steps are, or if there's a hiccup in the plan. Olmsted County's just done a great job with keeping all of us who are involved up to date on where we're at on a certain project.
And Susan, what are your key recommendations for other jurisdictions doing similar work?
Wow. I will tell you that after working with this team for almost 2 years, it feels like there's tons of recommendations that have come from this project. But I think a couple of them would be to really not be afraid to ask for things, to keep bothering your state partners. We are a state office, and like any big institution, right, there are things that there are barriers, and it's okay to keep working through them. But at MDH, it really helps us think about how we can do public health differently and really meet those foundational public health responsibilities. So, I came away from these coaching sessions with this project, and really I wasn't coaching. It was sort of the member by the side, the guide by the side. But I would come away and talk to all my colleagues and say, wow, we have just learned this. And so it really provided a lot for us to sort of ruminate and think about, how could we address this as a state health department? Again, we're a work in progress, but we are eager to make this work.
Wonderful. Thank you. That was the end of my questions. But if there's any last thoughts that any of you would like to add, please feel free.
I've been doing data analysis for 15 years, and I still get surprised at how long data cleaning takes. And so sometimes it's just asking for that grace and patience from our county partners of, we have the data, we're working on it, we're cleaning it, we've just run into some roadblocks. Thank you for your patience. But I think just patience and being open when you run into something like that.
I do think that, small health departments like ours would not be able to do any of this work without this partnership between the state, Olmsted County, and our region. And so again, thanking everybody for not giving up and for working through this. As much as it was on your behalf, it has helped me too in my department, and we're very grateful in the small areas that we can have this kind of data.
Thank you all so much for sharing your perspectives. We hope this case study provides useful information to state and local public health leaders nationwide as they develop their data modernization roadmap. Thank you for joining us.